So my name is Dennis McGuire. I'm a physician assistant with orthopedic surgery here in Northern California. And I want to do a quick video showing the nuts and bolts of how to put on a shoulder immobilizer brace or a DonJoy. So as we all know, the areas of contact for a sling are going to be your neck, because there's this strap going on here. It's going to be the elbow because of the exposure of this nerve here. And then also with a numb arm, it's going to be the wrist. So let me just say the goal is always going to be sort of your GI Joe position. So I think of it just really basically as kind of like your 30-30-30. So exactly, if you can just flex really fast. No, I'm just kidding. Damn, girl. Ow. Okay. So 30, abduction, forward, and then external rotation is what we're looking for. This helps the sort of the ball nestle right into the socket and leaves the most space for all the soft tissue around, whether it's going to be your capsule or your labrum after stabilization. That's not true. With your labrum, you're going to be a little bit tighter here, but still with your 30-30 there. But I think most importantly with this big bulky brace, we're thinking of shoulder replacements, which is going to be either your anatomic total shoulder replacement or your reverse total shoulder replacement. We'll get the specifics of that. And then also your proximal humerus fractures, which can actually result in the equivalent of a total shoulder replacement, depending on what they're doing in there. Okay, so let's go over to the specifics of the brace. The first thing I'm going to do is consider what the patient's going to be in. So I'm going to go from the front, where their arm comes out, and finish in the back. I like to have my strap long so I can do final adjustments to make it smaller. So what I do is just take the slack on the back on the buckle side. I'm going to shift this pad forward, and then on the back of the sling, this piece of strap is always going to be a minimum of a foot too long. So in the operating room, we will already have estimated, and if it hasn't been done, feel free to always cut slack off the back, because this is where you have your adjustable strap here. And you just sandwich it there. Be cautious because these are sharp, so I try to be really mindful of how I lay this onto the strap itself. That's going to be kind of where they can't reach. And so we'll do a fine tune there. The other thing we want to do is, in preparation for left side, I'm going to just open all these straps on one side. So the one that goes over the top and the one that goes in the first web space. And now these are sort of ready to go. Then with the abduction pillow, you can do the same estimation. Again, I like to take this slack out of the front. Your buckle is always going to be in the front. And then we will have already estimated the back slack. But if you feel like it's too redundant, again, that's where you would cut it shorter, because you have that sandwich Velcro piece that can be adjusted. So now I've already opened that top strap and the thumb strap. Obviously the buckle is going to go in the front. And what I'm going to do, this is an anesthetized arm. This is like a limp arm. I'm going to reach my hand in, and I'm going to just grab the patient's fingers and support it that way. You're never going to do harm holding onto a patient's fingers, because they can hold their own body weight that way. And then what I'm going to do is focus, this is important, focus on the elbow. The elbow, if you measure things from your elbow, you're not only going to get them fitted comfortably, but you're going to also protect them. You say, yes, so this is not a pull right now. This is just handing myself the buckle. I'm actually, so do you see how these sharp edges would be right behind her neck and on top of her neck pad? I like this landing halfway in between. So I have slack on both sides, but it's not, number one, bothering her neck, or number two, pulling on the pad instead of securing itself. So this is a fine tune that I think is super wonderful for a therapist to do, because the patient is standing up for the first time and you really can see where everything's going to lie. See how when I put that there, now that's going to be on top of her shirt or her gown instead of on her neck. And then the other thing that I want to make sure we pay attention to is that this strap is actually a lot easier for patients to adjust than the buckle. The buckle's pretty sexy and everybody wants to play with it, but reality is with arthritic hands, it's actually quite hard to do. So by having this tab and showing patients, look, you can fine tune your tension. I just took the weight off the wrist by putting it on the neck. And now what I can do is take it off the neck and then put it on the shoulder. You can actually, and I've done this, take this extra strap and for really arthritic hands and just eat up the distal part of the Velcro so that it's always hanging forward. So you see that, so that's like a super easy strap. The supraspinatus is the one muscle that's under, not the one, I'm sure you know of others, but the only one I know of that's under tension in anatomic position. It's under tension at rest. By abducting the elbow from the rib cage at rest, take the tension off your supraspinatus. So in an anatomic shoulder replacement, we still like to do that. It's a good way to nestle the ball into the cup too, but that's sort of what we're thinking when we have that in there. So if you have no post-op instructions and you're taking care of something that was a cuff repair, you just can know that we're going to protect it with that abduction pillow. So the most important thing about this pillow, honestly, is the position of the buckle. That's the biggest foul you can make, is not having the buckle in the front. And I know it seems obvious, but this whole thing is kind of black and buckly. If you put this with the buckle in the back, the patient's just trapped. Does that make sense? So we always want to go buckle in the front. And for your 30-30-30, it's not a great idea to have your wrist break right over the edge of this. Do you see how that actually doesn't give you your 30 external rotation? Now your whole thing is abducted 30 forward, elevated 30, but we are no longer externally rotated. So I like to make sure that my pillow is a little bit distal, supporting that wrist. That's going to go inferior ribs. And for your female patients with pendulous breasts, you just have to make sure that it's comfortable for them before you go. So now we can see if our abduction pillow is sort of anterior, we get that 30-degree external rotation. Can you see that? It's not even that perfect, but you get the idea. You can adjust it. You can bring it more anterior. And now is the time when we start closing things up. So now we're going to take this brace, slap it onto our induction pillow. So that is one way that we can hold that abduction pillow in place. See that? Then we're going to, so this brace is big for her, but that's okay with a dead arm. I'd rather it be too big than too small so your wrist isn't hanging out. But some people it's gonna fit, I'm gonna cheat you forward. Some people it's gonna fit like this. Now we're gonna put on the brace that goes in the first web space. This also is an area of complication. So if patients, their sling is too small, or it's not tight enough and their arm falls forward, like out that way, that way, do you see how they can have tension in their first web space and they can't feel their arm and they can wake up with a neuropathy or whatever it's called. So I'm gonna get you back in there. Now this is the important part to protecting yourself. So there's a belly strap. The reason why we want a belly strap is because, number one, if we don't, this pillow's gonna fall down. But more importantly, with your total shoulder replacements, we have to take down your subscap to get into your joint. So your subscap's coming across, we literally take it down with a bow V, tag it, flap it over while we're in the shoulder with sutures, tag it, pull it back over, drill holes in the distal humerus, and cinch that sucker back down. And it's gonna take 6 weeks for that to really scar in. So we don't want external rotation. So that's why we have this belly band on all total shoulders, and it's gonna go around and it's gonna buckle in the front, literally to prevent this. For patients who are like not tolerating this, I tell them why they're wearing it and say, my cue is wrist to belly button. I want your wrist resting on your belly button. When it comes away, I want you to have a little bit of a shock collar on and be like, ugh, I'm putting tension on my subscap. So that's the whole reason for that. So this is the other fine tune that you'll want to really show the patient. Say like, see how you can make this tighter for yourself, make it looser for yourself, and this is how you get out. That's actually really easy to do. I did not, she's teeny. So most patients I would have eaten up my slack a little bit more and not had this much slack. So let's say this would be sort of that kind of perfect adjustment so that the patient, when she wakes up and she stands up, and then she's got it on. So that's the other thing, that when they stand up, you can make sure that this back guy is eating up enough slack so that they can just do that really easily. I'm gonna now show you how to put on this shoulder immobilizer brace without the abduction pillow. So this will be for your, at our institution, for your stabilization, so labral repairs to like a dislocating shoulder, or for a reverse total shoulder replacement. So in the operating room, what I do, and I think it's worth you guys knowing this because not everybody is how to do this without, how to give them the belly strap without the pillow. So I harvest off this awesome Velcro, step number 1. And then I also, I don't know if you can see this in front of her black, but I also harvest off this whole strap. And all I'm doing is stealing the strap. On the buckle side, you've got a little bit of Velcro at the end, so I'll sort of use that too. So now we have no buckle and no pillow, and that's great. I cut this sucker in half-ish because it's so good. And I put one in the back and one in the front just to kind of accommodate everything. So before I had this strap going to the pillow. In this case now I have just the strap going over the top. And then when I put this on, I'm going to kind of capitalize on the Velcro. This is just style points, but I think what's important is that you see that it's sort of secure that way. And then I do the whole dance again. Okay, I have somebody on the other side. Tracy, go ahead and do a little bit for me. That's perfect. I'm gonna come over on the other side, do my tug of war. And now we don't have to worry about the pillow, but then what I'll do is, you'd leave a little bit of slack, but I just slap this guy right here, and then I just cut it. And that's something that you can be showing them so they can totally adjust that too. The thing you want them to pay attention to is number 1, their neck. How's this feeling? If it's too tight, you do your gross release in the back. I made that word up, but you know what I'm saying, like kind of big crude movements. Again, so that they can do their fine tuning with the strap in the front, right? Mm-hmm. All the way up. Sorry about your hair. If it's too tight, this shoulder's higher. So you can say like, I'm looking at you, have them look at their self. That's gonna mean that this is pushing up too high and it's gonna be putting pressure on their elbow, which is a risk. If it's too loose, their arm's gonna fall out the front. That is also going to cause a pressure on their first web space and the nerve there. So I think it's worth mentioning that. So it's kind of like your Goldilocks, you want to be right there, but what you're paying attention to, and I think it's worth letting them know, even though they can't feel their arm right now, it's all about the elbow. So what I do is her arm is hanging and I'm kind of shaking it and nestling her elbow as deep down into that corner as I can. Because once I do that, the rest makes a lot of sense. The risks of being braced is always going to be stiffness, and stiffness is painful. Mm-hmm. So once we start down this stiffness road, we're kind of pumping pause on our outcomes. So I think that what this ball is probably very good for is honestly encouraging movement, getting over a little bit of fear, but also the degree to which squeezing a ball is going to help with sort of lymphatic drainage in the arm that's stuck.